Welcome to The Explainer. I am so thrilled to have you with us today. Okay, let's just dive right into it, because today we're demystifying a highly complex but honestly incredibly fascinating world. We're talking about inpatient medical coding. Now, for those of you who've been working with the ICD-10-PCS code set over the last decade, you already know it's basically an intricate giant puzzle. But today, we're going to focus our lens on one specific, absolutely crucial piece of that puzzle. We're going to decode the device character.
So think about this for a second. If a surgeon leaves a part behind inside a patient, how do we actually track it? I always like to compare the human body to a highly complex machine, and sometimes that machine needs permanent new parts just to keep functioning correctly. When those new parts are installed, coders have to meticulously track them. It is a massive responsibility. The codes we use to report procedures for an inpatient are literally our ultimate tracking mechanism. But translating a surgical procedure into a specific alphanumeric code, well, that's an art and a science.
Section 1. Cracking the sixth character.
Section 2. The staying put rule. Right, so before we can even begin to decipher the complex clinical jargon found in a provider's operative notes, we first have to master the foundational rules. We have to define what actually qualifies as a device in the first place. The 2026 ICD-10-PCS Official Guidelines for Coding and Reporting lay this out super clearly for us. Guidelines B6.1a and B6.2a give us our golden rule. And it's this: a device is coded only if a device remains after the procedure is completed. Put simply, if nothing stays put, we just code the value no device. Now, in some limited route operations, the classification does give us specific qualifier values, things like temporary and interoperative. We use those for clinically significant devices where the whole purpose is just to utilize them for a brief duration during the procedure or maybe during that current inpatient stay.
But, of course, surgical plans can and do change mid-operation, right? So there's a really crucial exception to this rule. What if a device was intended to remain after the procedure, but it actually requires removal before the end of the operative episode where it was inserted? What do you do then? Well, the guidelines are clear. Both the insertion and the removal of that device must be coded. You really have to capture the entire story of what went down in that operating room. To really build some clear mental boundaries here, we need to contrast actual devices against materials that might feel like devices, but administratively they just aren't. We're talking about materials like sutures, ligatures, radiological markers, and temporary postoperative wound drains. Those are considered completely integral to the performance of a procedure. Because they're really just part of doing the job, they're not coded as devices. You literally just leave those out of that sixth character slot.
Section 3. Translating the provider's jargon. This is exactly where the medical coder steps in as a vital translator. You'll use tools like the ICD-10-PCS device key, which is this extensive chart right in your coding manual, to convert a provider's medical jargon into valid alphanumeric device values. Let's walk through a hypothetical patient to see this in action, okay? Imagine a provider documents the insertion of a delta frame external fixator to treat a fractured right tibia. Using the device key appendix, you build the code step by step. We start with 0 for medical and surgical, Q for lower bones, H for insertion, G for tibia right, 4 for percutaneous endoscopic, and then here's our star player. For this sixth character, the appendix guides us to D for external fixation device, hybrid. Finally, Z for no qualifier. The whole shebang results in the complete code 0QHG4DZ. That D just perfectly locks right into that sixth character slot to represent the exact device they used.
Section 4. A specialty deep dive. Now, beyond what's in the code set itself, coders often need to keep a medical dictionary close by. Why? Because different medical specialties use wildly different tools, and differentiating them is absolutely key to your success. For instance, just take a look at the fascinating, highly specific devices a neurology coder has to expertly distinguish between. In those operative notes, you might see character 1 for a radioactive element, character 2 for a monitoring device, character 3 for an infusion device, or character M for a neurostimulator lead. Each one of those completely changes the nature of the sixth character. And if we pivot over to a cardiovascular surgeon's documentation, the terminology shifts entirely. Now we're talking about tissue or tissue substitutes, like the ones used in bypass surgery. Accurately reporting these devices requires incredibly careful reading. You absolutely have to know the origin of the tissue. Is it autologous, meaning it came from another location in this patient's own body? Is it non-autologous, meaning it came from a donor? Is it synthetic, meaning it was artificially created? Or, get this, Is it zooplastic, meaning it actually came from another species entirely? That origin completely changes the code you select. Cardiovascular coders also have to deal with spatial terminology. The literal physical placement of a device changes everything. Intraluminal refers to a device placed within a tubular or hollow organ or structure. Think inside an artery or a vein. On the flip side, extraluminal indicates the device was placed on the outside of that structure. But wait, if a device is intraluminal, the detective work isn't over yet. Any specific characteristics of that device must be garnered directly from those procedure notes. You have to look for details like, is the device bioactive? Is it radioactive? Drug-eluting? You also need to count the exact number of devices inserted, whether it's 2, 3, 4, or more. All of these super specific details will direct you to the exact accurate alphanumeric character needed to report that specific device.
Of course, cardiologists don't just work in veins and arteries. They have long been adept at inserting devices directly into the heart itself. Let's do a quick rapid-fire look at some of these direct-to-heart devices used to treat conditions like heart failure or arrhythmias. We've got character J for a cardiac lead pacemaker, K for a cardiac lead defibrillator, N for an intracardiac pacemaker, and Q for an implantable heart assist system, which actually helps a heart pump blood more effectively.
Let's look at the functional stakes of these cardiac devices, because mistranslating the operative notes here, that's simply not an option. Consider the difference between a pacemaker and an internal defibrillator. A pacemaker is inserted with the expectation of regulating a heartbeat in a patient with abnormal rhythms, and it does this using low-energy mini-shocks. The internal defibrillator, however, delivers high-energy shocks to physically stop an abnormal heart rhythm and reset it back to normal from within. The source material notes, this is somewhat similar to what you see on television when emergency services externally care for an unconscious person. They sound related, but clinically, they are entirely different beasts. Section 5, Why Accurate Coding Matters.
Pulling back from this intricate grid system for a moment, why does all of this meticulous translation even matter? What is the massive real-world impact that this single alphanumeric digit actually carries? It's really important to anchor this seemingly dry administrative task right back to a real human patient. Finding the accurate letter or number to report the specific device used reflects the information documented for 3 vital reasons. First, yes, it ensures optimal reimbursement. Second, it maintains appropriate continuity of care, so the next doctor down the line knows exactly what is inside their patient. And third, and perhaps most crucially, it allows the medical system to track critical device recalls. If a specific synthetic graft or pacemaker fails out there in the real world, this code is exactly how they find the patients who need help.
Which brings us to our final and definitely most provocative thought for today. A single character in a 7-character code can trigger a life-saving recall. It can literally mean the difference between life and death for a patient years down the road. If the law states that you need to query the provider when you're uncertain, you absolutely must do it. So ask yourself, are you reading the operative notes closely enough? Thank you so much for exploring the incredible stakes of medical translation with me today. Keep learning, stay focused, and I'll catch you on the next explainer.